Good morning, colleagues. We will move now on to trochanteric fractures. X-rays was discovered by Röntgen in 1895. However, these upper end of femur proximal fractures were adequately described before the advent of X-rays. In a famous book by Sir Astley Cooper, he described and divided fractures of the proximal femur into three groups. One is an intercapsular fracture, the other is a basicervical, and the third is a trochanteric fracture. And comparing both, he realized that the trochanteric fracture heals well with exuberant callus and heals quickly in contrast to an intracapsular fracture. And hence, it has been known ever since and still is in the UK as an extra-capsular fracture of the femoral leg, also known as pertrochanteric or intertrochanteric fractures. The proximal femur is segment number 31, and hence, if you look at a proximal femur, the fractures are divided into A, which is a trochanteric fracture, a B is a neck fracture, and the C is a head fracture. A1 is a simple trochanteric fracture, A2 is multi-fragmentary, and A3 is an intertrochanteric. Now let's look further into that. The A1 is a simple fracture, either with a single isolated fracture as a greater trochanter or lesser trochanter. Commonly, two-part fractures that might have a small lesser trochanter fracture, but with a good thickness of the lateral wall. The A2 fractures are multifragmentary and have a lateral wall incompetence or deficiency. There are two groups, one with one intermediate fragment and the other with two or more intermediate fragments. The A3, or known as the reverse obliquity, is an intertrochanteric fracture, meaning that it happens between the trochanters. It could be an oblique one, or a simple transverse, or a wedge, or a multi-fragmentary. Now, these fractures are famous to happen in elderly patients, and they're known as fragility fractures if there is osteoporosis, and they usually have a suboptimal or bad outcome. There is a high readmission rate. There is an increased incidence of osteoporotic fractures in the increasing elderly population, and a high refracture rate of the other hip or the spine. So about 15% are readmitted within 30 days. Many become dependent following the fractures. 30% die within the first year. There is a definite reduction of mobility in 1/4 of the cases, and more than half would need a nursing home admission within 1 year. So the challenges in these patients are the medical comorbidities, physical impairment as poor vision, poor healing, weak muscles, poor balance, or mental problems, and at last but not least, the osteoporosis. So how are we going to manage these patients? On admission, the patients could have hypothermia, hypoglycemia, or dehydration that needs to be corrected. To optimize these patients to operate on within 24 to 48 hours, you need a multidisciplinary team approach. The geriatricians, the physicians, psychiatrists, physiotherapists, and occupational therapists. So now we come to the operative treatment. Principles are simple. Reduction, many cases can be achieved with close reduction. Open reduction is uncommonly needed. The fixation options are either a DHS or a DHS with a trochanteric support plate or a proximal femoral nail, all in very few indications replacement. This is followed by rehabilitation that is not straightforward. So how are we going to fix it? A1 simple fractures can be adequately fixed with a DHS. However, one should achieve accurate reduction, avoiding varus and rotation. The leg screw should be central in the AP and the lateral and within 10 millimeters of the subchondral bone. If it's very osteoporotic bone, we can deeply insert the leg screw up to 5 millimeters from the subchondral bone. Remember, the tip apex distance is important, and it shouldn't be more than 25 millimeters in the AP and the lateral added together. If it's more than that, there is a high risk of a screw penetration. Moving on to multifragmentary fractures, the A2 fractures. If it's got a thick lateral wall and the configuration is relatively stable, it can do with a DHS. If there is a lateral wall break during the operation, or the lateral wall is thin, either 20.5 millimeters or less, then the options is to use an additional trochanteric support plate or a proximal femoral nail. In A3 fractures, the intertrochanteric ones, you would need a proximal femoral nail or one of its variants like the gamma nail or the intertan or others. Replacement is done in very limited cases. Patient should be a walker, osteoporotic. The fracture is multifragmentary with fixation is likely to fail. In these cases, we can think of a primary replacement. Now, what are the advantages of the DHS? It is cheap, readily available, has a short learning curve, and it allows controlled collapse. And this controlled collapse will compress the fracture, enhancing the stability and healing, and minimizing the possibility of a screw cut out of the or penetration. Now let's look at some complications. If the fracture is not reduced properly, or the DHS is used for the wrong fracture configuration or for the wrong indication, it could fail. So it could break, the screws could break and the fracture displace, as you can see on the right side. The screw could cut out of the femoral head and neck. It could cut out and penetrate into the acetabulum, or even it could bend. Nails are not without complications. The screw could penetrate into the hip, or one of them would penetrate into the head or the hip joint. This is known as the Z effect. Also, nails could break. So in summary, you have to optimize the patient before surgery, operate within 24 to 48 hours, acute reduction and fixation is mandatory. For A1 fractures, the DHS would do. In A2 fractures, the stable ones, the DHS will do. If there is a lateral wall deficiency, you have to supplement the DHS with trochanteric support plate or a proximal femoral nail. For A3 fractures, use a PFM. So if a DHS or a nail is worth doing, it's worth doing right. إن الله يحب إذا عمل أحدكم عملا أن يتقنه. Thank you very much.